10 years in federal prison, $118 million in fraudulent healthcare claims. That's the outcome for one Texas physician convicted in a scheme built, prosecutors say, on diagnoses that were never real. According to federal prosecutors, the case centers on false patient diagnoses used to justify claims submitted to healthcare programs, and on August 14, 2026, the sentence became public record. The question here isn't hard to state, but it's hard to answer. How does a single medical license unlock that much money, and how long does it take anyone to notice? Over the next few minutes, we'll walk through what's actually been reported, the scale of the fraud, the mechanism prosecutors say made it work, and the sentence itself. We'll also talk honestly about what's still unknown, because in a case like this, what hasn't been made public yet is almost as important as what has. Start with what's on the record. According to federal prosecutors, a doctor practicing in Texas was convicted in connection with a healthcare fraud scheme tied to false patient diagnoses. The government's figure for the fraudulent claims is $118 million. The sentence, 10 years in federal prison. Those three facts, the false diagnoses, the dollar figure, the 10-year term, are the backbone of everything we know publicly, and we're going to be careful not to add detail that isn't sourced. Healthcare fraud cases often get retold with invented dialogue, invented scenes, names for people who were never actually named in the record. We're not doing that here. If a detail isn't confirmed, we'll say so. What's most surprising about a case like this usually isn't the size of the number. Healthcare fraud in the U.S. runs into tens of billions of dollars a year, so on its own, $118 million is large but not unprecedented. What's harder to explain is the mechanism. A diagnosis isn't just a note in a file. It's the single piece of paperwork that decides whether an insurer or a federal program pays for a test, a procedure, equipment, a course of treatment. Change the diagnosis and you change what's billable. That's the lever prosecutors say was used here, and it's worth slowing down on, because it's the same mechanism behind a huge share of the fraud cases the Justice Department brings every year. Cases like this are typically hard to build, and it's worth explaining why, even without case-specific details about the investigative obstacles here. In healthcare fraud generally, federal investigators, often the FBI working alongside the Department of Health and Human Services Office of Inspector General, describe the same problem over and over. Fraud dressed up as legitimate medicine looks, on paper, almost identical to real medicine. A false diagnosis doesn't trip an alarm in a database. It shows up as a normal-looking claim, filed by a licensed provider, for a patient who exists at a facility that exists. The paperwork is the crime, and it's built to look unremarkable. That's the general obstacle investigators in this field describe. Not a detail specific to this case, but the reason these cases so often take years to build, and one of the reasons the government leans on data analytics and pattern detection rather than waiting on single complaint tips. So how do cases like this usually start? There's no public account of how this particular investigation began, and we won't invent one. But in general, healthcare fraud investigations tend to open a few common ways. A billing pattern that breaks from a provider's peer group, a whistleblower, often an employee, filing a qui tam suit under the False Claims Act, or a routine audit by a program integrity contractor flagging statistical outliers. The False Claims Act is worth explaining as general context, since it comes up constantly in this kind of reporting. It lets a private citizen with knowledge of fraud against the government file a lawsuit on the government's behalf, and if the case succeeds, that person can collect a percentage of the money recovered. It's one of the most effective fraud detection tools the federal government has, precisely because so much fraud is invisible from the outside and only obvious from the inside. We've covered how a scheme like this typically works and typically gets investigated. What we haven't covered is what happens after a conviction, because a 10-year sentence isn't a number a judge just picks. It comes from a formula, and that's where this gets interesting. Federal sentencing in healthcare fraud cases runs through the U.S. sentencing guidelines, and the guidelines weight one factor above nearly everything else: the dollar amount of the loss. As the loss climbs, so does the recommended sentence range in fairly steep increments. A 6-figure fraud produces a very different guideline range than an 8-figure fraud, and $118 million sits well into territory where the guidelines call for a lengthy term. Judges aren't required to follow the guidelines exactly, but they have to consider them, and in large-dollar healthcare fraud cases, sentences around 10 years line up with what the guidelines typically recommend for losses of this size. That context helps explain the number here, even without the judge's specific reasoning, which hasn't been detailed in what's public. Here's the part that'll probably get pushback. 10 years, on its own, doesn't feel proportional to $118 million to a lot of people, and we get that reaction. Divide the sentence by the dollar amount, and it can look almost administrative, like a cost of doing business for anyone willing to take the risk. But that framing misses something. A federal fraud sentence isn't only the dollar figure. It usually comes with restitution obligations, which can force repayment of some or all of the fraudulent amount, and with exclusion from federal healthcare programs, meaning the ability to bill Medicare or Medicaid again is usually gone for good. For a physician, that exclusion can be a bigger practical consequence than the prison term because it ends the version of medicine that made the fraud possible in the first place. So here's the real open question. The $118 million figure and the 10-year term don't answer. What happens to the patients whose diagnoses were allegedly falsified? That's the part of healthcare fraud reporting that gets the least attention, and it deserves more. When a diagnosis is fabricated to justify a claim, the fraud doesn't stay contained to a billing system. It becomes part of someone's permanent medical record. A diagnosis that was never accurate can follow a patient into future insurance applications, future decisions made by other doctors trusting the chart in front of them, future life insurance or disability determinations. Undoing that is far harder than reversing a wire transfer. It's not clear from what's been publicly reported whether, or how, the false diagnoses connected to this case are being corrected in patients' records. That's a genuine gap in the record, and we're not going to guess at it. What strikes us about a case like this is what it reveals about the incentive structure under American healthcare billing. The system is built to move fast. Claims get submitted electronically in enormous volume, reimbursed on a timeline measured in days, not months. That speed is what makes modern healthcare logistically possible. It's also exactly what a fraud scheme depends on. High volume, fast turnaround, and a diagnosis code that a computer trusts because a licensed provider signed off on it. The doctor's signature is the whole security system. When that fails, the same volume that makes things efficient is what lets the fraud scale. That explains how a scheme reaches 8 figures. It doesn't explain how it gets caught. And the honest answer is we don't know the specific detection method here, but we do know, in general terms, what usually closes the gap between a scheme like this and a courtroom. Would you have noticed anything wrong sitting in an exam room if your own diagnosis had been altered on paper without your knowledge? Most patients wouldn't. That's the point. Fraud built on false diagnoses isn't designed to be visible to the person it's committed against. It's designed to be invisible to everyone except the billing system it's exploiting, which is exactly why these cases so often get uncovered from the inside. By billing staff who notice numbers that don't add up, by insurers running statistical models across thousands of providers, by federal auditors comparing one practice's diagnosis rates against the regional average. When a single provider's rate of a specific, high reimbursement diagnosis sits far outside the normal range, that's usually the first thread investigators pull. Worth pausing here to say plainly what federal law requires and what we'd say anyway. Everyone named or referenced in a federal fraud case is entitled to the presumption of innocence unless and until a court has determined guilt. Where a conviction has occurred, as reported here, that conviction is the outcome of the legal process, not our own assessment of guilt. We're reporting what prosecutors and the court record state, not handing down our own verdict. Would this doctor have kept operating if the scheme had never been caught? There's no honest way to answer that, and we won't pretend otherwise. What we can say is that the scale here, $118 million, suggests a scheme that ran for a meaningful stretch before it was caught, which lines up with a pattern seen across healthcare fraud broadly. These schemes are rarely caught in year one. They're caught once they've grown large enough and gone on long enough to become statistically impossible to ignore. So here's a real question, and we'd genuinely like to know what you think. Should healthcare fraud sentencing weigh the size of the dollar loss as heavily as it currently does? Or should it weigh the number of patients whose records were falsified more heavily than the money? Those are two different measures of harm, and right now the guidelines lean hard on the first one. Tell us where you land. We've covered the scheme, the sentencing math, and the patient record question that doesn't get enough attention. One more piece is worth explaining before we wrap up because it decides what actually happens next. A 10-year sentence isn't necessarily the final word. Convictions like this get appealed often, and it isn't publicly clear whether an appeal has been filed here. If one is filed, both the sentence and the underlying conviction can be contested, and the process can run for years before it's resolved. Restitution orders don't always result in full repayment either. Even when a court orders someone to pay back a fraudulent amount, actual recovery often falls short of the total loss because the money has usually already been spent, moved, or is otherwise gone by the time the order is entered. None of that is specific to this case. It's simply how these outcomes tend to play out across healthcare fraud sentencing generally, and it's useful context for what 10 years and $118 million actually means in practice versus what it might suggest on the surface. One detail that stuck with us, going through how these cases usually get covered, the sentencing headline is always the clean part. A number, a term of years, a case closed. What almost never makes the headline is the cleanup, the record corrections, the restitution that may or may not fully materialize. What a hospital, clinic, or practice does with a physician's patient panel once that physician can no longer treat them. That part of the story isn't finished, even though the sentencing is. Here's where this case actually stands, as of what's publicly known. A Texas doctor has been convicted and sentenced to 10 years in federal prison in connection with a scheme tied to $118 million in fraudulent healthcare claims built on false patient diagnoses, according to federal prosecutors. What isn't yet public, at least not in what we could verify, includes the specific investigative timeline, whether an appeal has been or will be filed, and how any affected patient records are being corrected. If those details surface later, they'd change parts of this story, which is exactly why we'd point you to the primary sources rather than to secondhand retellings, including this one. If a case like this makes you want to understand how federal investigators actually build a healthcare fraud case from the first anomaly to an indictment, that's something we can walk through in another video. Short version, it almost never starts with a raid. It starts with a spreadsheet.